I'll be discussing the genetics of hypogonadotropic hypogonadism and the role of gonadotropins in the same. So to start with the history of genetics in hypogonadotropic hypogonadism, this was a paper published in 1944. And by this time, people used to know that color blindness is an X-linked trait. So uh, in this particular family, they could there was a co-segregation of color blindness with the hypogonadism. So this was the first presentation of hypogonadotropic hypogonadism, and it was proposed that it is a X-linked disorder. But as time passed, after almost 10 years, there were patients, female patients, familial cases with the affected females were described, ruling out just isolated X-linked inheritance. And as the time passed, they also described the families with autosomal dominant inheritance with incomplete expressivity. So the some members of the family will just have hyposmia or cleft lip or cleft palate, but they would be fertile, and the kids will be affected hypogonadism. So it can be a autosomal dominant inheritance with incomplete expressivity. Furthermore, in next few decades, different non-reproductive phenotypes were described with the congenital hypogonadotropic hypogonadism, and they were unilateral renal aplasia associated with CAL1 gene, cerebral ataxia in patients with Gordon-Holmes and Boucher-Neuhauser, ichthyosis, bimanual synkinesis, in some patients retinitis pigmentosa. So for the discovery of the genes in patients with this particular disease, the most you can think of the GNRH1 can be the most possible genetic defect in such patients, and that is the reason initially the scientists studied this GNRH1 gene in such patients. So the Sanger sequencing was discovered around 1977-78, and there was a HPG mouse, which was a naturally occurring mouse in which there was a GNRH1 gene deletion. So by this time, people knew that there is GNRH1 gene is there, and they knew how to sequence it. So the first gene to be sequenced was the GNRH1 gene in 1989. They studied a fairly large number of patients, but they couldn't find anything in such patients. So almost for the next 20 years, different groups studied different bigger number of CHH patients, but they couldn't find any defect in the GNRH1 gene. Finally, in 2009, two different groups, one was by James Boligan, another was Chan. They published their first reports of GNRH1. So it was like a finding a needle in haystack. So even if it is the most probable gene theoretically, the GNRH1 gene defects are fairly rare in patients with CHH. So the first gene discovery in patients with CHH was a CAL1 gene. So GNRH1 they could sequence it, but they couldn't find in 1989. So in 1990, initially they could find out that some patients with X-linked, some patients with hyposmic hypogonadism, that is Kalman syndrome, they had associated ichthyosis, which was due to steroid sulfatase deficiency. And this particular gene, these particular patients were having a deletion in this particular part of the chromosome, that is XP22.3. So by this point of time, scientists knew that this gene was located in this particular area. And after just 2 years, this David Big group, they described that the CAL1 gene deletion is the causal gene for the Kalman syndrome patients. So this is the first genetic description in patients with Kalman syndrome. So when the people started studying the CAL1 gene, initially they thought that it will be contributing to large number of patients, but it was just contributing to just 4 to 5% of the patients with IHH. So still there were n number of genes to be discovered. And to further this, in 1997, after 5 years of CAL1 gene description, this Nicoloduru group, they published their first report of GNRH1 mutation. So the difference between these patients and CAL1 was these patients were normosmic and the inheritance pattern was autosomal recessive. And the most important thing was the variable phenotype. So some patients were having testicular volume of 10 to 12 ml, and some patients were having just testicular volume of 2 to 3 ml. So there was a difference in the reproductive phenotype in such patients. And even with this this gene discovery, the contribution of this gene was just 3% to the genetic etiology of CHH patients. And then subsequently, many genes were discovered, like this FGFR1 gene in 2003, which was associated with dental agenesis, bimanual synkinesis, cleft lip or palate. and this was contributed to more number of patients. So FGFR1 contributes to almost 10% of the patients in any hypo cohort. So afterwards, multiple genes were described in a small number of patients, and by 2020 now we know that more than 36 genes contribute to the genetic etiology of congenital hypogonadotropic hypogonadism. So it is one of the most genetically heterogeneous disorder. Apart from being a genetically heterogeneous disorder, sometimes some patients can harbor two or more variants in two or more genes, and this is defined as oligogenicity. So oligogenicity is known in previously it was known in retinitis pigmentosa or Bardet-Biedl syndrome, but with this discovery in 2011, 2010, even CHH patients, they can harbor two or more variants in two or different genes, and the number can be up to 2 to 5%. And this complicates the genetic inheritance. When you know that patient is harboring two different genes, so it will be little difficult to predict the inheritance pattern in the next generation. So it has got implication in the genetic counseling. To learn these different genes can affect different pathways. So we all know that GnRH1 neuron precursors, they arise in the olfactory placoid, and they have to migrate along with the olfactory axons to the olfactory bulb and then to the hypothalamus. So there are different genetic regulators for this migration, as well as once they are migrated to develop these GnRH neurons, there are different genes implicated. So for these genes, that is CAL1, FGFR1, FGF8, prokinetin, so these genes are responsible for development and migration of the GnRH1 neurons, and the other genes are there to just for the development in the hypothalamus. So if these genes are involved, patients will not have hyposmia. But if these genes are involved, patient can harbor both hyposmia as well as hypogonadism. And so these different genetics genes are divided as per their role in neuromigration, role in the development, as well as role in the GnRH, the gonadotropin secretion. And the clinical clues for this is you can have the clinical clue of sense of smell, as well as clinical clue of mode of inheritance. So there are all kinds of modes of inheritance are possible in patients with CHH. So it is genetically heterogeneous, as well as all possible modes of inheritance are present in CHH patients. So the CAL1 gene, we know that it is a XLR gene. In such families, one or two male members will be affected, and on the maternal side, the maternal cousins will also be affected. So it is a classical example of XLR inheritance. We all know that CAL1 gene is a XLR. Apart from CAL1, DAX1 can be another gene which can be X-linked and which can cause hypogonadism along with adrenal insufficiency. Then comes the middle pathway genes, that is FGFR and prokinetin genes. These genes can cause autosomal dominant inheritance. So there is a vertical transmission. So the father had just hyposmia, but he was fertile and he could father almost 5 kids. And in these children, some of the siblings were having just isolated hyposmia, and some of them were having isolated hypogonadism. And one brother was having both hyposmia as well as hypogonadism. So it is a classical example of autosomal dominant inheritance, but with incomplete penetration. So his father had just hyposmia, but he was fertile. Another mode of inheritance, which is also possible, is AR. So in this particular inheritance, both brothers and sisters will be affected in the same generation. Along with that, if there is a presence of consanguinity, it will add upon to it will give additional weightage to this AR pattern of inheritance. So apart from this inheritance, there are different non-reproductive phenotypes in such CHH patients. So some patients can have renal agenesis, which is described in CAL1 patients, and synkinesis, which is described in CAL1 as well as FGFR1 patients. Musculoskeletal problems and with midline defects like dental agenesis, polydactyly, campodactyly, that is fixed flexion deformities of the fingers, or clinodactyly, these all have been described along with cleft palate in patients with FGFR1 or FGFR8 mutations. And hearing defect is also described in such patients, in patients with CHD7 as well as SOX10. So whenever you get a patient with Kalman syndrome, you need to look for ultrasound KUB to look for the renal agenesis. You need to get for the Puritan audiometry to look for any sensory neural hearing deafness. As well, you need to get a MRI to look for any olfactory bulb agenesis, as well as to rule out any masses in the cellar area. But having said this, having described all these non-reproductive phenotypes, many of the patients are there who will not have any kind of non-reproductive phenotype, and in most of these patients they will have nomosmia. So this non-reproductive phenotype as well as just the mode of inheritance is not going to tell you which gene is responsible for this patient. And to study the genetics, our department started doing the genetic study from 2008 onwards, and this is initial data of Sanger sequencing of 5 genes in 135 patients, published in Clinical Endocrine in 2015. So in these 135 patients, only 5 genes were studied, that is CAL1, FGFR1, FGF8, GnRHR, and KIS1R. So in 5 genes, in these 135 patients, the RSV detection rate was 15.5%. So please note this term RSV. So this is a rare sequence variation detection rate. Nowadays, no journal will accept this particular term. Now the terminology has changed. So in this particular paper of ours, the detection rate was 15% and oligogenicity was 1.5%. And we had few novel findings in this particular study. When we compared this particular Sanger sequencing data with the world literature, the CAL1 and FGFR1 percentage of patients in our cohort was comparable to the world literature, but the patients with GnRHR was significantly more in our patients compared to the world literature. So we had more of GnRHR patients. And amongst these GnRHR patients, there was one particular variant, that is C279Y. It was recurrent in 4 of our patients. And when we look back into the literature, there was one patient described in the literature, but the patient was again from the Asian ancestry. It was a Pakistani patient. So we hypothesized a possible founder mutation effect in this for this particular variant in our paper. So after this Sanger sequencing data, we studied the CHH patients with next generation sequencing. So before that, these CHH patients, sometimes they can have a syndromic hypogonadotropic hypogonadism, and these are different syndromes in which patients can have hypogonadotropic hypogonadism along with some syndromic manifestation. And to describe few, this is our experience with our syndromic hypo patients. So this is a patient of with hypogonadism, which is central in origin. He also had cerebral ataxia with cerebral atrophy on the MRI with mental retardation. So this is a patient with Gordon-Holmes syndrome. Another very rare patient who had CPHD. She was having ectopic bright spot, this triad, APH with ectopic bright spot with interrupted stalk. In addition to this particular finding, she also had hyposmia, the anosmia, which was proven with UPSIT as well as MRI showing olfactory bulb aplasia. So there is a genetic overlap in patients with CPHD as well as hypo, and it is very well described in the literature, though it is very rare. Coming to the next syndromic hypoego, there is another syndrome that is called as Baucher-Neuhauser syndrome. In such patients will have hypogonadism with cerebral atrophy, which leads to ataxia, with retinitis pigmentosa, which can lead to blindness. So to move ahead with the world literature, because this CHH is the more than 35 genes, more than 39 genes are implicated in patients with CHH. It is almost impossible to sequence each genes with using Sanger sequencing. So we moved ahead with the patient with the targeted next generation sequencing in patients with CHH. And for this, we used a clinical exome gene panel, which consisted of 4,800 genes. And amongst these 4,800 genes, we particularly look for the 29 known genes which are implicated in hypogonadism. And we could identify these 43 patients with these different genetic variants. And to look for any predictor of genetic positivity, so we had 43 patients who harbored pathogenic or likely pathogenic variant in CHH genes versus 107 patients who were mutation negative. And to look for any prediction of genetic positivity, we studied different factors. So Kalman or nomosmic or cryptorchidism or male female was not predictive, but the severity of hypogonadism. So the severity of hypogonadism is based on the reproductive phenotype. So any patient whose testicular volume is 4 ml or more is considered as a partial phenotype in males, and any female who has got any breast growth, that is B2 onwards, is considered as partial. So with testicular volume of less than 4 ml or no breast growth is considered as a severe patient with CHH. So higher is the severity of the reproductive phenotype, more is the genetic yield. So severe patients are they are likely to have a mutation positivity compared to the mutation negative patients who will have lesser number of severe patients. And as we all know, the familial cases will have a more genetic yield compared to the non-familial cases. When we sub-studied the normosomic cohort of 72 patients, again similar finding was found to us. The patients with severe phenotype had a more molecular percentage of more molecular diagnosis. That is almost 45% patient had some or the other genetic yield in such patients compared to the partial phenotype patients only in whom only 20% of the patients harbored genetic etiology. So this term is also very important, the molecular diagnosis. So if you sequence, if you use next generation sequencing in patients with CHH, you are going to find a large number of variants in such patients. But molecular diagnosis can be reached only in the presence of pathogenic or likely pathogenic variants in the known CHH genes when present in the zygosity matching their inheritance pattern. For example, we all know that GNRHR gene is inherited in autosomal recessive pattern. But if you find a GNRHR gene in a heterozygous state in a patient with congenital hypo, even if that mutation is pathogenic, because it is present in the heterozygous state, which cannot explain the genetic causality, which you cannot consider that as a molecular diagnosis in that particular patient. So this molecular diagnosis is very important, and this is very clear after 2015 guidelines by American College of Medical Genetics. So it is like a Bethesda testing for our thyroid FNSC. We should always consider pathogenic and likely pathogenic variants only, as opposed to benign or likely benign variants. There are some patients in whom some variants are there which are classified as variants of unknown significance. In such patients, you can use the segregation analysis, or functional studies are required to definitively say that whether they are causal or not. For molecular diagnosis, we always use pathogenic or likely pathogenic genetic variants only. So to review the world literature, so these are the 8 studies till now before our study, which used next generation sequencing in patients with CHH. And every study had a very significant number of population, at least 50 or more, except 1 or 2 studies. And they also studied large number of genes, but the causal number of genes which are known known to be implicated in CHH patients were 40 to 60. And if you see that molecular diagnosis could be reached in just 30 to 40% of the patients. And when you see if the number of patients, if the study included more than 100 patients with CHH, for example, in Casatella or Zhu et al. Or in Amato, the molecular diagnostic yield was just 20 to 30% only. For example, 22% in Casatella et al., 20% in this Chinese study Zhu et al., and 26% in this Brazilian cohort. So this clearly shows that still there is long way to go in patients with to unfold the genetics of the CHH patients. Almost 50 to in 60 to 70% of the patients, we don't know the genetic etiology, and probably whole exome sequencing is going to help. And from a study, we could add something to the literature. For example, GNRH1, which is very, very rarely described in patients with CHH. So these are the 8 patients till now described in the world literature having GNRH1 gene with only 5 variants described till now. And in our study, we could find 2 patients with 2 novel GNRH1 variants, which will be the addition to the literature. Apart from this GNRH1 novel gene, 2 genes, we could also identify this particular variant of GNRHR, that is PT32A, which was recurring in 4 patients in our cohort. And this particular variant is not reported in any other ancestry apart from the Asian ancestry. So we hypothesize that this another variant having a possible founder mutation, in addition to this C279Y, which was described in the previous study of ours. So for the genetics of CHS, the genetics of CHS is very heterogeneous, and all kinds of mode of inheritance are possible, and the oligogenicity makes it more complex. And there can be patients with variable inheritance. There can be patients with just hyposmia or cleft lip palate who can be fertile, but the offsprings of their patients, these patients can have complete hypogonadism. The non-reproductive features may not help you always, except very specific, like renal agenesis, which is mentioned in Calvin gene, or retinitis pigmentosa or ataxia, which is mentioned with the PLPNA gene. And the genetic yield was found to be 37% in our patients with using the NGS technology, and almost 4% had oligogenicity. GNRH-R gene was more common in our patients, and this P271 and T32A had a founder effect. So we discussed the genetics of hypo now, which is very heterogeneous. Now coming to the treatment, what is new in the treatment of patients with CHH? So the gonadotropin treatment is new in such patients, and it's not new, but it should be revisited. So we all know that when the HPG axis gets activated, it will have the implication on pubertal induction with the achievement of secondary sexual characters, as well as the fertility induction, that is achievement of spermatogenesis. So both are needed to call it as a complete pubertal induction. So secondary sexual characters can be easily achieved with the exogenous testosterone replacement, but we don't just want the secondary sexual characters, we also want fertility for our patients. And this 2015 consensus statement of CHH clearly mentions that gonadotropins or pulsatile GnRH can be used as a mode of pubertal induction in such patients. And they use these two particular words, HCG alone or combined. We will be discussing this afterwards. And when you use gonadotropin-based treatment, they have got very good physical and psychological outcomes. And this was proven in a RCT in a small Japanese cohort. So this gonadotropin-based treatment is not new. It was already known in the literature, and this 1979 article clearly mentions the different protocols for gonadotropin-based treatment in patients with hypogonadotropic hypogonadism. So in our department, we started this pubertal induction from 2010 onwards, and gradually the number of patients were increased. And in initial few patients, we always started these patients with the combined gonadotropin. So we used to start these patients with HCG with a small dose 5,000 to 500 to 1,000 twice a week subcutaneous, along with HMG. So we used to start the combined gonadotropins at once only, and gradually every 3 to 6 monthly, with the monitoring of these parameters, we used to increase the dose, and the maximum dose used to be 2,000 thrice a week in most of the patients, and HMG will be maximum dose will be 150 thrice a week in such patients. And the endpoint of our pubertal induction used to be adequate virilization along with good testicular volume buildup, and which is stable even with continued gonadotropin treatment. And once patient used to achieve this pubertal induction, we used to shift patient on androgen or continue SCG monotherapy after the discussion with the patient. And these are few cases in which in whom we use gonadotropin-based treatment for pubertal induction as well as fertility with very gratifying responses. So this is a 15-year-old boy who presented with delayed puberty, but because he had a complete absence of smell, we were confident enough that it is a patient with Calvin syndrome, and we should start treatment. And subsequently, he turned out to be a patient with carrying Calvin mutation as well, a pathogenic mutation. So in this patient, we started with a small dose of HCG and HMG, and gradually we built up the HCG and HMG dose with a maximum of 2,000 and 150 units thrice a week. And you can see that from the baseline testicular volume of 2 ml over a period of almost 4 years now, his testicular volume is 15. Because his testicular volume continued to grow, we continued the gonadotropin-based treatment. And you can see that he has reached almost a normal testicular volume with this continued gonadotropin-based treatment almost for 4 years. And with a very gratified response in the both in achievement of testicular volume as well as achievement of the secondary sexual characters. So gonadotropin can be very well successfully used for pubertal induction. So can we use this gonadotropin treatment for other patients? So this is a case in whom I would like to highlight that this gonadotropin-based treatment can avoid surgeries in patients with cryptorchidism and with in CHH patients. So this is a 10-year-old boy who presented to us with a small size phallus along with bilateral cryptorchidism. On detailed family history, he had maternal cousins with hyposmia. So we are pretty confident that this patient is having some familial Kalman syndrome, and the MRI also revealed absent olfactory bulbs. And you can see that he is having hypoplastic, very poorly formed scrotum with a small phallus. because we were fairly confident that this patient is having CHH and he was not had mini puberty, which will help in most of the patients with cryptorchidism for the descent of the testes. So we tried to mimic the mini puberty in this patient. We started this patient on HMG 150 thrice a week for almost 4 months, and after that we added HCG to this HMG, and after almost after 5 to 6 months, you can see that his scrotum developed well. There was descent of these inguinal gonads, and they remained in the scrotum only. So we could successfully achieve the descent of the undescended testes, as well as increase in testicular volume and enlargement of the SPL size. So in this particular patients, we avoided surgery for the cryptorchidism, and we successfully used gonadotropins. And after this patient, we use this particular gonadotropin-based treatment for almost 5 different cases, five another patients with CHH only with successful response. So having discussed the benefit of gonadotropin-based treatment in patients with for pubertal induction as well as cryptorchidism in CHH patients, this is another patient who presented to us very late at 25 years old. And by that time he had already married, and he had come to us that he's not able to father a kid, and he has got very poor secondary sexual character. So you can see that he was having a very severe phenotype with testicular volume of just 1 to 2 ml, and very low level of gonadotropins as well as testosterone. In this patient also, we started combined gonadotropin treatment, that is HCG as well as HMG. And after almost 17 months of treatment, 27 months of treatment, he had got a very good spermatogenic response, that is 32 millions per ml. And now, after almost 3 years of treatment, he has fathered a baby. And on genetic analysis, he is harboring very rare biallelic GNRH1 variant, missense variant in GNRH1 gene. So this is another example of successful gonadotropin treatment for fertility. So in this patient, we can call it as a pubertal as well as fertility induction, because he was not exposed to testosterone previously. He was directly started on combined gonadotropins with a gratifying response. So not every patient will respond wonderfully like these patients. This is another example of 24 years old male with severe phenotype with a small testicular volume with absent secondary sexual characters. And his younger brother was also affected. And so this is a case of familial severe normosmic hypogonadotropic hypogonadism. So in this patient, we started with combined gonadotropin treatment, and gradually with 3 to 6 monthly, we increased the dose of SCG as well as HMG. But even after almost 40 months of treatment, there was no sperm. So he was having azoospermia, and the fructose was positive. So ruling out the obstructive cause of azoospermia. But if you look at the testosterone, he had very good testosterone response. So this is a patient who had responded to gonadotropin-based treatment only in terms of achievement of the testosterone, but there was azoospermia. So we decided that we label this patient as a failure to the gonadotropin response in terms of spermatogenesis, and we shifted to the injection testosterone. So can we identify such patients and allow patient for to go for another fertility management like sperm donation or ICSI or TACI? So we need to know predictors of gonadotropin-based treatment and predictors of response in such patients. So this is a JCM article published in 1988, which has touched to this predictors of fertility in such patients when we use gonadotropin treatments. And you can see that the testicular volume, so higher is the testicular volume, better is the response as well as fertility. And as the number of cycles of gonadotropin response, gonadotropins goes up, the response gets better. But if you look at the prior androgen use, if the patient is already exposed to the androgen, so in most of such patients with CHH, the traditionally everybody used to start patient on testosterone replacement therapy. But in such patients, this prior androgen use can be a negative predictor factor for fertility, which eventually patient is going to need. So we should be aware of this particular entity, that if the prior androgen use can have implications on future fertility, negative impact on the fertility in such patients. And why is that? We just discussed that thing only. So we have to understand this negative impact of the testosterone prior androgen use on fertility. We need to know the physiology of androgens and FSH. So whenever a patient with CHS is given FSH, there will be increased number of seminiferous, there will be lengthening of the seminiferous tubules as well as the increase in number of Sertoli cells. But once the patients are exposed to the testosterone, whether it is exogenous or whether it is endogenous, after the patient started on SCG, there will be palisading of Sertoli cells and there will be differentiation as well as maturation of the Sertoli cells. So Sertoli cells are not going to further replicate and grow in size. Similarly, the seminiferous tubules, they will differentiate and they will stop growing further once they are exposed to the testosterone. And again, this is proven with the biochemistry. As we all know that this AMH hormone is produced by the immature Sertoli cells. If you give just FSH to these patients, AMH is going to go up because the number of Sertoli cells are increasing. But once these patients are exposed to the testosterone, this AMH is going to go down because once the Sertoli cells mature, the mature Sertoli cells, they don't produce AMH. So this testosterone exposure is going to produce the maturation of the Sertoli cells, and this is so why these Sertoli cells are protected in mini puberty? Because in mini puberty, these patients produce the testosterone level as good as the adult testosterone levels, but in mini puberty, the Sertoli cells, they don't express enough androgen receptors. That is the reason they are not adversely affected. But as we grow in age, the androgen receptors, the number of androgen receptors, they grow up in the Sertoli cells, and they can have negative impact if these patients with CHS, they are if they are given just testosterone before they are given gonadotropins. And to study this hypothesis only, this particular group by Revio et al, they had studied just 3 patients, and this 3 patient series was published in 1997 in Lancet. So what they did, they gave just FSH to these patients, and you can see that just by giving FSH, the inhibin B, which is again secreted by Sertoli cells, it goes up. So Sertoli cell number can be increased with FSH pre-treatment. And to further this, they studied, they did a RCT, small RCT, including just 13 patients. So what they did, they studied patients with CHH either on recombinant FSH followed by GnRH versus only pulsatile GnRH. So those patients who were given recombinant FSH prior to the pulsatile GnRH, they had a better sperm concentration. You can see that these blank circles are the patients who are given recombinant FSH before they were given pulsatile GnRH, because once the patient is given pulsatile GnRH, it is going to produce LH as well as testosterone. So before the onset of testosterone, if you give just FSH, there is a beneficial effect in this small study published in 2013. And similar experience has been with in our department. So we have got almost 40 patients with who are treated with gonadotropins, and you can see that those patients who are given just FSH prior to the combined treatment, they had a better sperm concentration. So you can see that the other groups who were given combined gonadotropins, that is FSH as well as SCG at 0 hours, compared to these patients, the HMG pre-treated patients had a better spermatogenic potential, and this number is now almost 7-8, and that data is being collected. So apart, if you exclude these 5 patients, the rest of the patients become 35, and this 35 patients were separately studied by our recently passed out resident, Dr. Ravi. And so if there were 2 groups, one is pubertal induction group. So in these patients, gonadotropins were used to directly induce fertility, induce the puberty. So these patients were not exposed to the testosterone. Compared to other group in which these patients were already given testosterone for very long duration. Now these patients they came for the fertility point. So these 17 patients were in the pubertal induction and 18 patients were in the fertility group. So if you just study the severe phenotype, so any patient with baseline testicle volume of 4 or less, if these patients were given if these patients were given combined gonadotropins, that is HMG as well as SCG, before they were given testosterone, the response was much better. You can see that the number of patients reaching more than 1 and more than 5 million is much higher in patients with the patients in pubertal induction cohort. And what is the difference? So these patients were never exposed to the exogenous testosterone before they were exposed to the gonadotropins. So in patients with severe phenotype, If the patients are exposed to the testosterone for a longer duration, there can be a detrimental effect on the Sertoli cells as well as seminal tubules, impacting their future fertility. So we need to keep this particular point in patients with the CHH patients with severe phenotype before we start them on the definitive treatment. But so in patients with severe phenotype, prior testosterone has a adverse outcome, poorer outcome. But when you study partial phenotype, so partial phenotype means any patient with baseline testicular volume of 4 or more ml. So if the testicular volume is very good, it is indirectly suggesting that the patients has a good number of Sertoli cells. So even if these patients are exposed to the prior testosterone, the spermatogenic potential is not very different. So in patients with the partial phenotype, even if you expose these patients with the testosterone, the outcome may not be very different, but it is different in patients with the severe phenotype, and we should remember this point in our practice. And this particular paper is recently published in the Pituitary journal just a few months back. So based on this experience, now we have modified our pubertal induction protocol in our severe phenotype patients. So patients with testicular volume of 4 or less ml, 4 or less. So in such patients, we always start with FSH, but recombinant FSH is little costlier, hence we use HMG. We start with 75 units thrice a week. And after 3 months, we check the inhibin B level. If the inhibin B level is very good, if it is more than 100, yeah, and last few slides. If it is more than 100, it is adequate response, and we start the patient on the low dose SAG. And if the response is poor, we increase the HMG to the 150 units thrice a week, and then we add subsequently the HSG. And the final dose of SAG should be 2000 thrice a week. Any higher dose like 10,000 or more is not going to produce any better response. So this should be the maximum dose in most of the patients. And the endpoint is adequate utilization as well as testicular volume, which is at least 10 to 12 ml, or it is not increasing further over a period of next 6 months. And once we achieve this induction, we can shift the patient on the androgen therapy or the SCG therapy. So in our patients with severe phenotype, we start with the FSH pre-treatment and then only add the SCG. And in partial phenotype, we can start with the combined treatment. And as discussed by Anurag sir in last talk, in patients with acquired hypogonadism, they can have a FSH sparing effect. And in such patients for induction of fertility, you can use the SCG alone. So that is the end of the talk. Yeah, thank you.